So today I'm just going to give a really brief snapshot of the behavioral health population and tobacco-related disparities, and we'll look at some evidence-based treatments tailored to this group, and then also improved health and recovery outcomes from quitting smoking. So we'll just dive right in here. One more. Thank you. So I just listed a few common characteristics among the behavioral health population with their tobacco use. So they typically start smoking at an earlier age than the general population. They are also heavier smokers, have then greater nicotine dependence, also then greater difficulty with quitting smoking, and can experience greater psychiatric, cognitive, and medical comorbidities. So there are many challenges with this population and their smoking, but the high rates of smoking and lack of cessation treatment that's provided are two that are heavily contribute to tobacco-related disparities among those with behavioral health conditions. If we look a little bit closer at the tobacco disparity, adults with any mental illness or substance use disorder represent about a quarter of the United States population, though they consume just about 40% of all cigarettes smoked by adults. So this group is not only more likely to smoke, but they also tend to smoke more cigarettes daily and smoke them harder, so right down to the very butt. And here we see prevalence rates among different mental health and alcohol use disorders. The far right column shows the smoking rate of the general public, and it was around 19% at the time that this data was assessed, so to keep in line with the rest of the percentages here. But typically we see the more severe the mental illness, the higher prevalence of smoking, and the rates of smoking among those affected by mental illness and substance use disorders are at least 2 times higher than the general population, and can be up to 4 times higher or so in some instances. And the rate of smoking today is about 14%, but there hasn't been as steady of a decline or much of a decline among the behavioral health population, so they still remain at a very high average of about 40 to 41% smoking overall compared to that 14% today. So tobacco smoking causes more deaths among clients in substance use treatment than the alcohol or other drug that brings them to treatment. So they're more likely to die from a tobacco-caused disease than from their drug and alcohol use. And among the 480,000 deaths a year in the US due to smoking, it's estimated that about 200,000 of those, or about 4 out of every 10 tobacco deaths, are people affected by mental illness and substance use disorders. If we look at mental illness, smokers with mental illness have increased risk for cancers, lung disease, cardiovascular disease. They also die several years sooner on average than Americans without serious mental illness. So the toll of smoking heavily and for so long not only impacts the quality of life, but also the quantity. So these populations are dying up to 25 years earlier than the general population, and smoking is that single largest cause of gap in this life expectancy. So then, do the behavioral health care delivery system provide tobacco dependence treatment? So there was a survey of about 26,000 treatment facilities, so you can see mental health treatment facilities on the left and substance abuse treatment facilities on the right. And clearly there's work to be done. So screening for tobacco use, about 50% for mental health facilities, 60% for substance abuse treatment facilities. But then we see the declines in actually providing the evidence-based treatment. So counseling is much lower, and then providing cessation medications, either nicotine replacement therapies or the non-nicotine prescription pills. Only about a quarter of that population is receiving treatment from those behavioral health facilities. So again, work to be done there. And when we compare this to primary care, for instance, these numbers are much lower, especially with screening for tobacco use. Typically that's, high 90s, 100% of inpatient, outpatient kind of primary care facilities are screening for tobacco use and still have higher rates of providing treatment as well. And that's due to many different misconceptions, and we don't have time to go into all of those today, but again, work to be done in that area. So we know that these folks want to quit, they do quit, but they do also find it much harder to quit. So those with behavioral health conditions are, they've contemplated quitting within the last 6 months. They're about as likely as the general population to want to quit smoking. Looking at a survey over 3 years, these quit rates. So those with no diagnoses, general population is about 22% or so. And then you can see with mental illness, substance use disorders, and serious mental illness, those numbers are much lower than that general population. So while the quit rates might not be as high as that general population rate, we know that they can successfully quit. So these numbers are showing that they are able to quit, they can successfully quit. It can be higher if they are provided that evidence-based treatment and support. So because many people affected by mental illness and substance use disorders are trying to quit without using evidence-based treatments, I wanted to give an example of how and why they might associate smoking with managing their behavioral health condition or use smoking as kind of self-medication. So we'll look at anxiety, for example. These are common symptoms that someone experiences when they have anxiety. So of course, all unpleasant. They can be interrupting of someone's day-to-day life, sometimes debilitating, but overall just uncomfortable as well. And then when we advance and look at nicotine withdrawal, you'll see that many of these symptoms of nicotine withdrawal are similar or the same as anxiety. So when someone is quitting, especially without using cessation medications, their body is going into nicotine withdrawal, and it presents these symptoms that very closely mimic anxiety. So that person might then think that smoking or self-medicating with cigarettes helps their mental health, and that when they try to quit, their anxiety or mental health is much worse. So really just underscores the importance of educating about nicotine withdrawal and absolutely using cessation medications among this population. So then getting into treatment. So the clinical practice guideline, along with the American Psychiatric Association and NIH, all agree that the same tobacco cessation interventions that are effective in the general population should also be used with smokers affected by mental illness and substance use disorders. Those that are willing to quit should be offered a combination of counseling and pharmacotherapy, and then also that it should be a standard of care to address tobacco use and provide treatment among this population. And looking at the evidence-based treatments then, so these are what we know are best practice, and they're effective among all populations. So of course, counseling and medications combined, using state quit lines as treatment extenders, so providing state quit lines as a resource support, and then also just common relapse prevention techniques and follow-up. But traditional cessation treatments, such as monotherapies or just the standard medication dosing and duration, may, however, not be adequate for people affected by behavioral health conditions. So there are some extra assistance and tailored strategies that we can use to help that population succeed. So we can take a look at some different treatment considerations for this population. So it's important that those with behavioral health conditions may benefit from treatment that is of greater intensity, but also duration than what's typically provided to the general public. So these are just some suggestions here, and I don't have time to go through all of them, but can highlight a couple. So reducing smoking to reach abstinence or before their quit date. So that gradual reduction in smoking to eventually reach abstinence as opposed to quitting all at once may be more helpful for some. Also using pre-quit NRT with smoking reduction. So it's a strategy that can not only help with more success in quitting, but also can motivate reluctant smokers to make a quit attempt. So they're just replacing some of the cigarettes they would normally smoke with the nicotine replacement product, so they can reduce that smoking, less cigarettes, but also get used to the medications and help with the withdrawal, and that can help increase their odds of abstinence up to 4 times as well. And then one other thing to point out, two other things actually, I'll talk about practice quit attempts, and that may be beneficial for this population, less stressful, less pressure to succeed. So a practice quit attempt is just, again, practicing that quit attempt. So kind of an unofficial quit attempt, and it's an opportunity for that population to become comfortable with using the medications, and lessen withdrawal symptoms with using those medications, and then working on kind of those behavioral change strategies. So just one option there. And then also pointing out calling the quit line with the tobacco user. So of course, quit lines can be a very helpful resource for this population as well, but it might be beneficial to assist in calling the quit line at least the first time that they're getting connected with them. Many times this population isn't able to trust strangers, especially over the phone, or that they might not have had a good experience with using the quit line in the past. So to be able to make that call with somebody that they trust, have built up that rapport with, might help them get more comfortable with using the quit line as a resource for them. All right, and then I'll move on to looking at improved outcomes. So addressing tobacco improved substance abuse outcomes. So alcoholics who were provided tobacco treatment during their addictions treatment, they were associated with a 25% increased likelihood of long-term abstinence from alcohol and illicit drugs. So contrary to some common concerns, smoking cessation interventions during addictions treatment appears to enhance rather than compromise long-term sobriety. And then also with mental health, quitting smoking will not interfere with mental health recovery. Their mental health symptoms do not worsen when they quit. And over time, cessation actually improves mental health outcomes. So a meta-analysis had found that compared to those that continued to smoke, smoking cessation was associated with significant improvements in depression and anxiety and significant reductions in stress. And the amount of reduction in anxiety and depression was equal to or greater than what would have been expected from medications used to treat anxiety and depression. So huge benefits on mental health, and also looking at medication burden with those on psychotropic medications. Smoking increases the metabolism of certain psychiatric medications. So when someone quits, they often need to go on lower doses and see a decrease in side effects. So that can be a huge benefit to somebody who might be taking multiple medications a day to be able to lessen that burden. So that is all I have for you today. A very quick whirlwind on this really broad topic, but I hope that was helpful for all of you.
Thanks, Amy. Any questions, immediate questions for Amy?
Laura, it's Frank. I just want to comment on what she just said about the drug interactions with smoking, because we have found, especially in this population, that that's a big issue that most people aren't aware of. So very quickly, the hydrocarbons in the cigarette smoke, and be careful, this has nothing to do with nicotine. The hydrocarbons in the cigarette smoke rev up the metabolism of many, many medications. So in most cases, if you're smoking, you need nearly twice as much of the med than you would if you weren't smoking. And most of those medications that are affected are psychiatric meds. If we teach this in the RX for Change program, and I do have a chart that I can send you that you can distribute to everybody that lists the primary medications that this affects. But the issue here is that you really should be monitoring these people very closely when they quit, because they don't need, as Amy said, as much medication after they quit than they do before they quit. And what we have found that if you don't do that, many people start experiencing what are really side effects from having too much medication, but they interpret that to be withdrawal symptoms. So they go back to smoking, and it does work to prevent to stop that. So the issue here is that many times what they think are withdrawal symptoms are really side effects from too much medication. So my advice is just if you have anybody in this population that is quitting, to monitor them very carefully in terms of how much their meds are, and don't be afraid to lower the amount because they don't need as much, which is a selling point, as Amy just said, to many people, because a lot of these individuals hate taking medication. So if you can tell them that they're going to be taking less, and indeed they will be, that may be a selling point to help them find a motivation to quit.
That's great. Thank you, Frank and Amy. Super important points on that, both for people who are trying to quit to lower their medicines. And then I imagine the reverse is true also, that patients maybe are smoking and have behavioral health conditions and their medicines aren't high enough, so they're smoking more. So you have to sort of make sure you're treating their mental illness or substance use disorder appropriately, and then help them start to quit, and then lower their medicines. So yeah, super duper important point. Yeah, that's great. I mean, that chart would be great, Frank, if you want to share that. We'll get it out to everybody. It'd be nice
Okay,
to have.
I'll send it to you today.
Great. That's awesome. Thank you, Frank.
Hey, Laura, can I ask one question?
Yeah, go ahead. Yeah.
You know, I think these are great points and really enjoyed Amy's presentation. And I mean, this is a question for Amy or Frank or anybody. But, you know, we've raised this up with a lot of docs and providers at health centers. And there's always a good portion that come back with kind of the standard retort, which is, well, we can't take everything away from them. And, you know, we mentioned the fact that the data shows that their outcomes will be better without it. But I guess, how do you convince them, or is there a certain progression for making that switch and getting, you know, their patients with behavioral health issues, you know, or substance abuse issues off of cigarettes?
Bob, this is Steve Schroeder. Let me give you one solution that might be helpful.
Sure.
That's old school. That's the way it used to be, and they're behind the times.
Yep.
Because the culture is shifting, and now the standard among all the leadership organizations is to help people quit. So if they're adhering to old school wisdom, they're behind the times, they're risking becoming obsolete.
Okay, we'll give that a shot.
And Bob, this is Frank. I would point out what Amy just talked about, and the fact that these people die sooner, much sooner, than the general public. So you're not really, you are taking away something from them if they continue to smoke, and that's their health. Yep. So you're giving them good health if they quit.
Yeah, that's great. And I'd also add to that, we believe that behavioral health providers are the most apt and equipped to provide cessation treatment to this population. I mean, they're doing it every single day with other addictions, with other treatment and recovery that they're providing. And it's just a small little shift to address tobacco. But they have all of the skills necessary to provide this. And we think that they are very equipped to do so. So to highlight that too.
Great suggestions. Thanks very much.
Yeah, super great. Yeah, thanks everyone. And then also, you know, in the health center space, well, in the primary care space, I would say in general, but the health center space for sure, as, you know, behavioral health, primary care integration has become, you know, really so commonplace, and that's important and should be commonplace. But to have your medical care providers and behavioral health providers working together and doing those warm handoffs and learning from each other in the tobacco cessation world, that's great too. Super important. Thanks. Those are great questions and helpful.